911 Global Meds Disclaimer. This video and any contents herein are posted on this YouTube channel of 911 Globe Meds for informational and educational purposes only. Please see the detailed video contents disclaimer and the copyright disclaimer in the text section below.
So I must say that we were pleased with the 6-year results of APHINITY because with the first analysis of results, I must confess to you that we were a little bit disappointed. The reason being that dual HER2 blockade with trastuzumab and pertuzumab in metastatic disease has been found to be incredibly effective. In the Cleopatra trial, the double blockade in combination with the taxane led to very important improvements in progression-free survival and also overall survival. So as we are transferring this strategy from advanced disease to early disease, we were all expecting to see something striking. And the first analysis showed a benefit, but very modest, almost not clinically meaningful, I would say. And now with the 6-year results, for the node-positive patients, the benefit, the magnitude of the benefit is 4.5% for invasive disease-free survival, and this we consider clinically meaningful. These were really very nice news. Now we continue to see no benefit at all in node-negative disease. We could not understand that because what we thought is that perhaps if we go a little bit deeper and analyze these node-negative patients in view of other factors like age, tumor size, presence or absence of tumor-infiltrating lymphocytes, that we should find a subset benefiting. And so we did run a step analysis. You know, this is a complex statistical method that sometimes helps you identifying a group of patients with a constellation of factors that will derive significant benefit from the new treatment. And it was a failure. So we are still completely unable to identify patients with node-negative HER2-positive breast cancer benefiting from dual HER2 blockade. So this treatment should not be given in routine clinical practice. The other message from the step analysis was that all the node-positive patients benefit. So that's interesting too. What we also could see is that there are still patients with a high composite clinical risk score that will have a greater than 20% risk of relapse in spite of dual HER2 blockade. So it means that there is still room for further improvement. But on the other hand, it's going to be difficult to investigate new strategies in the adjuvant setting, because what APHINITY told us is that a lot of these patients do very well today. So you need huge trials to obtain a certain number of events and be able to see a difference between two treatment strategies. So personally, I think that what we will see in the future more and more are trials in the post-neoadjuvant setting, because at least there you know that the patients who have this residual disease after neoadjuvant systemic treatment have a significant risk of relapse, and you don't need trials of 5,000 patients. Perhaps trials of 2,000 patients will be good enough.